So there are two problems in hemoglobins that can lead to hemolysis or premature hemolysis of the RBCs. One problem is sickle cell anemia or sickle cell hemoglobin, and the other problem is thalassemia. In thalassemia, we all know that abnormal hemoglobins are formed, which can lead to hemolysis. So we have discussed thalassemia already. So we will just discuss sickle cell anemia here as a cause of hemolytic anemia or hemolysis. Again, the presentation of hemolytic anemia will be like other hemolytic anemias, that is anemia with macrocytosis or normocytic anemia, reticulocyte, increased reticulocyte count, jaundice, and dark color urine. What happens in sickle cell anemia? Polar amino acids such as glutamate is replaced by non-polar valine in each of the two beta chains. So if polar amino acid is glutamate is replaced by non-polar amino acid valine in both of the chains, then it is known as sickle cell disease. And if only in one chain it is replaced, then it is known as sickle cell trait. So a patient with a history of what happens in sickle cell anemia. In sickle cell anemia, the sickle hemoglobin due to this replacement of glutamate by valine, uh, whenever the hemoglobin is deoxygenated in a deoxygenated state, this sickle hemoglobin, it polymerizes and causes RBC to sickle. Normally, the shape of RBC is biconcave disc shape, but due to this abnormality in the hemoglobin, what will happen in a deoxygenated state, the hemoglobin will polymerize to form a sickle shaped RBC. And this sickle shaped RBC, all the problems arises to this sickle shaped RBC. The first problem that will arise due to sickle shaped RBC is that it will be broken down by spleen because of its abnormal shape. And the other things that it can cause is that due to this sickle shaped RBCs, small blood vessels or microvasculature will be blocked. So micro blood vessels will be blocked due to this sickle shaped RBCs, and it will result in ischemia. Wherever this happened in the microvasculature, ischemia will result. So a patient with sickle cell crisis, sickle cell anemia can develop a different type of crisis. One crisis we have already discussed, that is aplastic crisis. And aplastic crisis arises due to infection with parvovirus P19. There are two other crises that a patient with sickle cell disease can develop. One is thrombotic crisis or vaso-occlusive crisis, and the other is sequestration crisis, and the fourth one is hemolytic crisis. Vaso-occlusive crisis and sequestration crisis and aplastic crisis, all three of them are important. Hemolytic crisis, it is less important because it is a very rare. So we'll discuss these three one by one. The most common type of crisis that a patient with sickle cell anemia can develop is thrombotic crisis or vaso-occlusive crisis. What will happen? What happens in this thrombotic crisis due to sickle-shaped RBCs? The blood vessels of the different organs are blocked. This sickling can result due to cold. It can result due to infection. It can result due to stress. It can. So these are the different precipitating condition: cold, infection, stress, and dehydration. Some patient would know their triggers and develop strategies to avoid them, but majority of the painful episodes or vaso-occlusive crisis does not have any identifiable cause. So whenever occlusion occur, intense pain will occur and infarction will occur in various organs. So what are the examples of the organs in which uh, infarction can occur due to this ischemia? So if small vasculature of the gut are blocked, then it will result in mesenteric ischemia. So if someone with a history of sickle cell disease present to you with features of acute abdomen, you will suspect vaso-occlusive crisis. Vaso-occlusive crisis can cause avascular necrosis of femoral head, and it can cause acute chest syndrome if it blocks microvasculature of the lung. So someone with a history of sickle cell disease present to you with features of pneumonia, then you will suspect acute chest syndrome. The management of vaso-occlusive crisis is supportive. That is, for pain, we'll give analgesia. And if the patient has developed acute chest syndrome or mesenteric ischemia, then empirical antibiotics and oxygen will also be given if oxygen saturation is low. Now, the second type of crisis is that a patient with sickle cell disease can develop is sequestration crisis. So what will happen if the sickle-shaped RBC, they block the blood vessels of the spleen. So due to blockage of the blood vessels of the spleen, uh, the blood is sequestered in the spleen, or there's pooling of red blood cells in the spleen that lead to enlargement of the spleen. So all the blood is pooled inside the spleen due to blockage of these blood vessels. So what will happen if there's pooling of blood in the spleen? Blood will become unavailable to general circulation. So a decrease in hemoglobin concentration, circulatory collapse or hypovolemic shock, and death may also occur. Sequestration crises usually occur in babies and in young children. In sequestration crisis, there will be increased reticulocyte count. In aplastic crisis, we discussed that low HB will be associated with a decreased reticulocyte count because there is aplastic crisis. Bone marrow is suppressed, so reticulocyte will not be produced. So decreased HB, low HB with low reticulocyte count, it will be aplastic crisis. And low HB with high reticulocyte count, it will be sequestration crisis. Is this point clear to everyone? How you can differentiate between sequestration crisis and aplastic crisis in patient with sickle cell disease. In both of them, the HB will be low. In sequestration crisis due to pooling of RBCs in the spleen, and in aplastic crisis due to bone marrow suppression. The differentiating point between these two is that in sequestration crisis, because there is no problem with the bone marrow, so reticulocyte count will be increased. But in aplastic crisis, there is problem with the bone marrow, so reticulocyte count will be decreased. Is this point clear, everyone? So this was all about sickle cell anemia and different type of crises that are present in sickle cell anemia. The management of all of these types of crisis is supportive, that is painkiller for pain and blood transfusion if severe anemia. Again, parvovirus B19 can cause aplastic crisis in hereditary spherocytosis and sickle cell anemia. Let's discuss an example. A 19-year-old male known case of sickle cell anemia presents with pallor, shortness of breath, lethargy, and headache. So, a 19-year-old male who is a known case of sickle cell anemia, this is how a question about sickle cell anemia and hereditary spherocytosis will be asked in the Plab 1. So, someone with a history of sickle cell anemia present to you with pallor, shortness of breath, lethargy, and headache. So, these are the signs of anemia: pallor, shortness of breath, lethargy, and headache. They are all the signs of anemia. So it can either be an aplastic crisis or it can be a sequestration crisis. How we are going to differentiate between these two? Let's read the other remaining question. For the past week, he has been having flu-like symptoms. He also complains of joint aches on his hands, wrists, knees, and ankles for the previous few days. So he complains of he is having flu-like symptoms. Flu-like symptoms signifies the diagnosis of parvovirus B19. He also complained of joint aches on his hands, wrists, knees, and ankles for the previous videos. His HB is 56, so low HB. A doctor is suspecting a parvovirus B19 infection. So whenever you see parvovirus B19 in a patient with sickle cell anemia or hereditary spherocytosis, your diagnosis will be aplastic crisis. So the likely diagnosis is aplastic crisis. A short summary of vaso-occlusive crisis, sequestration crisis, and acute chest syndrome and aplastic crisis.
There's
Diagnosis of sickles. What?
thrombotic and vaso-occlusive process, both are same.
Yes.
Okay.
The diagnosis of sickle cell anemia is made on initially peripheral blood smear, which will show sickled RBCs and uh, hemoglobin electrophoresis will show. So whenever you want to diagnose a problem in the hemoglobin, such as sickle cell hemoglobin or thalassemia, your definitive investigation will be HB electrophoresis or hemoglobin electrophoresis. If hemoglobin electrophoresis show HBSS, then it is sickle cell disease, or if it shows HbA12, hemoglobin A12, then it will be thalassemia. Folic acid, blood transfusion, penicillin prophylaxis, and avoiding the precipitation such as cold, dehydration, and exhaustion is the management of sickle cell disease. Though not for important for Plab 1 exam, but for your knowledge, a drug hydroxycarbamide can sometimes be used uh, in the management of sickle cell disease. Splenic infarction can lead to hyposplenism. So we need to give antibiotics prophylaxis uh, in the form of oral penicillin to avoid infection. And immunization or vaccination can also be done. So this was all about sickle cell anemia. So far we have discussed the hereditary or genetic causes of hemolytic anemias. The first one was an enzyme deficiency, G6PD deficiency. The second one was a defect in the RBC membrane, hereditary spherocytosis. And the fourth one was sickle cell anemia, a defect in the hemoglobin. And the fourth one that we discussed in the previous lecture is thalassemia. So these are the four important causes of hemolysis, or genetic or hereditary causes of hemolysis. Now we are going to discuss some acquired causes of hemolytic anemias. Acquired causes they include autoimmune hemolytic anemia and microangiopathic hemolytic anemia. We'll discuss one by one and that what are autoimmune hemolytic anemias and what are microangiopathic hemolytic anemia.